My friend and everybody participating in this course. It is basically, we used to do this kind of educational meeting yearly, and the idea behind that to meet these nice colleagues and invite our colleague from abroad to just give us a brief so we can communicate and we can share the thought and ideas. I would like to announce a few things before we start. I don't want to make it quite lengthy because already we are a bit late. We're waiting for our colleague to arrive. And just a safety and security announcement in case if any fire alarm or anything is gone off, please just there's a sign take you to the exit, and please don't use the lift. I would like to thank Merck for their support for our educational meeting. And I would like to give a brief history of our faculty member. I hope it's going to work. So I try to give. Okay. Most of the people participate in this educational meeting that's well known, and they have really big background, a long actually history of educational and academic experience. We'll start with Professor Baris Ata. He's associated professor in Turkey, associated from Istanbul Medical School. He has a long experience in obstetric and gynecology, has his training in Turkey, then he has a McGill University 3 years program in reproductive medicine. He has many publications in peer-reviewed journals, and he has big academic experience and get many awards for his patient care experience and for developing a lot of idea and thought in reproductive medicine in Turkey. So welcome, Professor Ata. The second one, I think, is Professor Dr. Luciano. I think Luciano is not arrived yet. I share Luciano the same club. Me and Luciano, subspecialty. I met Luciano 19 years ago. He's subspecialty from Manchester. I'm subspecialty from Cardiff. I get my MD from Birmingham University. I appointed as a consultant senior lecturer in Birmingham. Then actually before I moved to Kuwait, I worked with CARE as a consultant lead in IVF and PGD program. And then actually went to the private sector in Kuwait about 10 years ago. Maybe next month will be 11 years. Luciano has big experience in academic in many areas, mainly in PCO, endometriosis. He published a lot of paper about AMH and ovarian reserve. He's working private sector at the moment in North UK in Manchester, and he's the leading clinician in a reproductive health group. So we're happy to have Luciano here. Dr. Delaim Al-Hajri is doctor from Kuwait. Dr. Delaim is well known for his interest in male factor fertility. He has a Saudi board, trained in Saudi Arabia. He has a lot of experience in andrology, male factor fertility, mainly interested in micro-TISA for surgical sperm retrieval in azoospermic men. So welcome Delaim as well. Dr. Kalyubi is an old new friend. Dr. Kalyubi has his degree from Ain Shams University. He has master's degree. Then he moved to Australia in Melbourne. He worked in reproductive medicine for a few years before he moved to Dubai in Fertility and Gynecology Center, I think, in Dubai. He's really keen and passionate about helping patients. Has a lot of interest, mainly in ovarian hyperstimulation syndrome. So he's going to entertain us today as well. Another speaker, we have Geraldine Emerson. Geraldine is a senior embryologist, is a lead in Faqih, Fertility and Reproductive Medicine Center in Dubai and Abu Dhabi. She's advisor and quality control manager. She has long experience. I had a chance to not meet Geraldine, but to visit where she trained in Dublin. I went to this small village used to work with is it Kirkcaldy? So that was 20 or 19 years ago. Just I went for academic visit and I met the person there. Maybe I met her, but I don't know if she knows me or know her. But Yes, Johnson. She had a car accident, I think, and then he left her work.
Unfortunately, she passed away.
Sad, sad. She's a nice lady. The other speaker is Nasser Samer. Nasser Samer is absolutely pioneer in reproductive medicine and genetics. He's the scientific advisor for genomics. He worked as advisor in Miami Center, and then actually was advisor for all genomics center around the world. He has his degree from Valencia. He graduated as pharmacist and then actually moved to the biotech and reproductive medicine. He has many publications. He's very experienced in monitoring the labs, and he has even clinical experience with counseling the patient. He has a PhD from Valencia. He has long track academic experience and publication. We are happy to have Nasser today as well. I would like to thank all our speakers and wish we have a nice day. It's absolutely fantastic weather in Kuwait. We are very happy to meet all our colleagues we did not meet for ages maybe, and to welcome everybody from Kuwait and from abroad as well. Welcome to our meeting. Thank you. So we're going to start the first lecture because I think we make a bit, and we do apologize for the delay. I hope I find my paper. Tamer, where's Tamer? Did you save my? I'm going to start the first presentation about. We chose this presentation to have something in general, so it will help all the participants and the audience to understand reproductive medicine in general. And it's a really important title or subject, Factors Influencing Reproductive Outcome of ART. Because all of us, we need that, even actually gynecologists, general gynecologists, IVF specialists, even urologists, because during the discussion and during the presentation we discussed why all our colleagues, they need to know much about this kind of factor influencing IVF outcome. So the point I'm going to cover in the lecture, we have to have a small introduction. Then we're going to talk about patient characteristic and its effect, starting with the age, ovarian reserve, which including anti-Mullerian hormone, basal FSH, antral follicles count, and in ovarian volume. And we have to mention the cause of infertility. Is it a tubal factor, the severity of the tubal factor, then endometriosis and leiomyomas and its effect as well. Can you make it dark here, please? I think we need to leave the light there and make it dark here. And then duration of infertility as a factor, then history of previous pregnancy, and then the rank of IVF attempts, how many IVF attempts you had before, then obesity, smoking, ethnicity. This is the patient characteristic. Then we'll move to the clinical characteristic and its effect, stimulation protocol, the unit itself, number of embryo transfer technique we use, and then embryo preservation program we are actually using in the unit to help have the cumulative pregnancy rate. And then we'll talk about ICSI and IVF, comparing ICSI and IVF, and then IVF laboratory, what we can do to add to our patient. And we hope we can conclude what we are saying in about 40 minutes or less than that. As you know, about 50% of our patient, or actually infertility couples, require ART to have a realistic chance of pregnancy. In another word, when you have infertility patient, especially through the last 2-3 decades, most of the people, they go for assisted reproduction technique because it does actually give a good chance of pregnancy. We don't have to waste the patient time, because it's very important, the calculation from the time patient tries to get pregnant until she gets pregnant. This is the time important. So you have to look at this period depending on the patient age and many factors as we're going to discuss. So the majority of our patients in the end, if they would like to have a realistic chance of pregnancy, they need to go for ART. And our ability actually to help infertile couples significantly increased through the last 2 decades. We used to know that, before they create or discover ICSI in 1993 by Palmer in Belgium, the chance of IVF the chance of pregnancy through IVF treatment for somebody has severe oligospermia or azoospermia 0. So before ICSI, you cannot treat somebody as azoospermic to have a baby. We need at least, as you may be aware, 5 to 6 million sperm to do IVF and then when they discover XC, or actually pioneered XC, and that was actually the big jump, and that was actually, we did help our patient too much, especially the male factor fertility through the last decade. Now, if you look at this slide, this is the number of IVF patients has been treated in UK from 1991 to 2014. I have the slide 2016, but I'm sorry, we did not update it. This is from HEFA, HFEA database. Look at that, in 1991, less than 10,000 cycles. By 2016 is 80,000 cycles a year. So basically, the number of IVF cycles has been increased too much, significantly. And the reason behind that, the facility, many centers, it has actually become like a private sector support for the National Health Service in all the world, in Europe, in America, even in the Middle East, and especially in the Gulf. As you notice, the cycle has been increased definitely. And that not because the number of the patient increased, only because the chance of pregnancy become higher. So the patient has more, she's eager and more ability actually to go for IVF rather than to go for many cycles before, when the chance of pregnancy was very low. So understanding the factor affecting the outcome of IVF is really important, and equally important to everybody, as I say, to gynecologists, to IVF specialists, to male factor fertility practice. And because there's some factor you can change it. For example, if somebody had hydrosalpinx, you can correct the hydrosalpinx and improve the chance of pregnancy. If she's obese, we advise her to lose weight. So there's some characteristic we can change and some characteristic we cannot change. So understanding this factor make you give the right advice to the patient and go through smooth and reproductive kind of treatment. And it's really important to compare the published data of IVF, because if you don't have a kind of classification for the data, then it will be disaster. Everybody say, I'm the best. I am actually a pioneer in the result of IVF pregnancy. You know, you judge by our result, all of us. So people started claiming, especially in UK in 1993, 1994, that's everybody saying, well, I'm the best, I'm the best. So the HEFA put a kind of rule. The age of the patient, they divide them less than 38, over 38, and now over 40, and say what the chance of pregnancy according to this classification. And however, the way how you actually choose the patient, it does affect the data. If somebody had a lot of IUI and convert the IUI to IVF, these people have high chance of pregnancy. You cannot compare them with somebody actually from the beginning or the starting IVF, because their chance will be less. So the factor important, there's many factors important, what the cause of the fertility important. So to publish the data, you have to have the difference, what kind of patient you select, and actually publish according to these factors. And to be honest with you, it's not like before. We used to be the doctor, before he's doing his practice, to come to the patient and say, well, we're going to go for IVF today, and there's nothing else. It has absolutely changed, the time changed. You have to discuss with the patient involved in the decision, and she's actually one of the decision making in the starting the treatment, even any kind of decision in the medical field. So educating the patient, tell her your chance of pregnancy, there's absolutely, it does help you and help the patient and reduce the litigation problem. And unfortunately, we are very bad in that, especially in this part of the world. And we need to know that the patient is absolutely a patient. He's a human. You have to discuss with her chance of pregnancy. And the worst scenario, when you come to the patient and say, well, your chance of pregnancy is 65% for IVF. Okay, her chance of pregnancy is 65%, but can you compare that chance with her chance of pregnancy spontaneously? And this is actually the right result. So you tell her your chance of pregnancy 65% or 45%, comparing with your chance of spontaneous pregnancy 15%, and then she'll know what she's going to do. But if she's actually 22 years old, their chance of natural pregnancy 45%, why need to go for IVF? So this one help us. We'll discuss maybe that in matter. So understanding this factor make you individualize decision making, which protocol to use, which kind of treatment to use for the patient, and then calculate her chance appropriately and actually give her the right chance of pregnancy, and that must be documented in the file. You cannot say, well, your chance 55%, and something can say, we told you 55, but there's 45 that can get pregnant. You have to discuss it properly and give the patient the right advice. So this factor, as we say, is important for everybody. Now, the patient characteristic, as you say, difficult to change most of them. You cannot change the age. You cannot change the ovarian reserve. But you can change a few factors which could help. If we're discussing the age, which I think the most important factor in my opinion, and difficult to change it, is any woman's ability to become pregnant decrease with age. That's in natural pregnancy and then IVF as well, or assisted conception technique. And this is really important factor. I don't know, maybe because this generation, or actually the old generation, or our generation in medical school, they did not teach us the effect of the age. Still a lot of people, they do a lot of mistake, or there's another thing we don't understand. And this is very strange, because when you discuss the factors, we'll discuss with you how people, they do something is totally different and not right from the general protocol or from the guidelines of the colleges and the guideline from the general medical practice. So live birth, late birth standard cycle has declined from 32. If somebody 30 years old, this is live birth rate, not pregnancy rate, live birth rate, to something around 2% for somebody 45 years old. And this is actually the data from HFEA. So there's a reduction in the implantation according to the age. Each year you have 7% less implantation rate when the people actually over 37 years old. So if she's 37 years old this year, her chance of pregnancy 45, next year will be 39, the other one 32. So because the chance will be less. Not only the implantation rate, of course, the chance of pregnancy as well. And the IVF cancellation rate quite high with old age group. Just find somebody actually, we find somebody, there's two studies by Mardisk and by Khaldoun Sharif, our colleague who did that in Birmingham. We find people over 40 or between 38 to 40. The chance of cancellation 50% comparing to about 18% for somebody less than 30 years old. Now, if you look here, this is the age, and this is the percentage of pregnancy. Let's talk about live. This is single infant live birth rate. You could surprise why the pregnancy high and then the single pregnancy, because most of them, and just to know what actually kind of model treatment they have around that time, basically. And we find the treatment option, the first option, laparoscopic salpingectomy, laparotomy salpingectomy, salpingostomy, proximal tubal occlusion, ultrasound aspiration during egg collection or before egg collection. Now you can add another one, hydrosalpinx aspiration plus sclerosis. You inject alcohol, 80%, you inject, for example, if the hydrosalpinx 20 ml in size, you aspirate 20 ml of hydrosalpinx, you inject 10 ml of alcohol, 80%, methylene, and then you can aspirate them after 10 minutes. And that make her have adhesions, and the tube never going to be refilled again, like when they inject tetracycline in the pleural effusion, so they prevent that fluid to come back again. That's really very effective. I reviewed an article last year, and when I review an article, I like it. We're going to start doing that, and it's absolutely fantastic kind of idea. They are very good in this kind of treatment. China, Taiwan, and Japan, and they have now, I think, 3 or 4 publications of that. So, but if you put the figure together, it is not 100% because each person uses more than one treatment, so they're not 100% if you add them together. We did a randomized control trial for hydrosalpinx aspiration, and we published in 2008. Look at that. For aspiration group, the clinical pregnancy 31.3, and this one 17. Look at the miscarriage rate, 28 here, and then 42. So basically, it does not prevent the implantation only. It does not reduce the chance of pregnancy. It does increase the chance of miscarriage. And this is logic because the washout and the negative impact of the hydrosalpinx fluid in the embryos. And I believe in this method because this is very helpful in one case. When you have, sometimes you do HSG or you do laparoscopy, the patient is absolutely fine, no hydrosalpinx. And during the treatment, you find the tube has been filled by fluid. So you have two options, either to cancel the cycle or to go ahead. I think to cancel the cycle everywhere, the patient never like this kind of decision. They pay a lot of money, and nobody like it. Even the doctor doesn't like it, the clinician. So basically, I sprayed the hydrosalpinx during the egg collection. You have to be very careful to spray the hydrosalpinx in the end to prevent actually transfer the infection, the communication with the other tube, the contamination, sorry, with the other tube, and make her have PID or pelvic infection. We cover them with antibiotic like augmentin, 1 dose, and then augmentin and azithromycin for 3 days only, and never have infection. This we can actually talk about it for hours and hours, but it's not the right time for it. So the endometriosis, the second cause, one of the, I think, major cause of fertility in Europe. It is less in the third world. We don't know if because the patient doesn't complain in the third world or just because actually it is the disease of the modernization. Nobody knows. The effect of endometriosis is exactly unclear. Nobody knows. It does affect the quality of the eggs. It does. It does affect the ovarian reserve. It does. But the best advice for everybody and for me, please, when you have somebody with endometriosis, you try to treat the patient as early as possible with a proper treatment, IUI or IVF. to do control ovarian stimulation is absolutely wasting time. Because this patient, the endometriosis is going to be more severe. She will go for surgery, will lose a bit of the ovary, no pregnancy, another surgery, and then in the end will have dimensioned ovarian reserve or low ovarian reserve, and she never get pregnant. So you have to take a decision a bit early. So the live rate is significantly lower in patients with severe endometriosis. We know that. The database did not show actually low pregnancy, but this data from 1999, because unfortunately we did not have a data. That data from the HIFA is not publishing now the factor. They're publishing a kind of management actually database about the number of the patient, the treatment number of the clinic in UK. So they become less involved in the clinical issue, and they left it for the researcher to do that. Sorry. So if you look at the endometriosis here, this is actually analysis for multiple logistic regression analysis for endometriosis comparing with control group. This is pregnancy rate in endometriosis, the control group could be tubal factor or anything. So 25% here, 29%. And it's not significant, but it's quite clinically significant. If you look at the fertilization rate, it's really very strange. I mean, fertilization rate is quite high, but there's no explanation for that. Sorry, it's quite low, but if you look 59% and 65%, I found that slightly high in severe endometriosis. But if you look here, endometriosis only with tubal factor, pregnancy rate 25, here 27. If you look here, severity of the endometriosis, stage 1 to 2, endometriosis pregnancy, look here, 21, 27. But if you look at the here, sorry, this is the fertilization quite high here, but that's very strange. There's no explanation. It could be, you can interpret that. Could be wrong result from the lab, could be wrong result from the data, nobody knows. But definitely affect the implantation, pregnancy rate, even the severe, worse than the mild, which means grade 1 to grade 2 of endometriosis. If you look here to compare grade 1 and grade 2, pregnancy rate, look at 13.4, here 21. Fertilization, I say, we don't know why it's high. Implantation rate, look at the different, but look at the main oocyte, 6, and this is 8. So it's quite, this is significant really, because severe endometriosis, most likely she has surgery. If it's not surgery, waiting for a long time until the mild becomes severe endometriosis, and then reduce the chance of pregnancy. So still, I mean, IVF is still the most successful kind of treatment for endometriosis, and please don't waste time control ovarian stimulation and say, well, it's only cyst, endometriotic cyst will aspirate that and you're absolutely fine. Endometriosis is a systematic kind of illness. It's not a cyst or spot. It is absolutely kind of illness. We don't know the reason for that and the cause. So please, endometriosis patient for IUI, maximum 2 to 3 cycles. And of course, you have to take the age in consideration. If somebody 39 years old, even IUI is not useful. You have to go for IVF. And this is the problem we have. Now, this is the problem because we are less educated or because we are doing that for another purpose. It's really difficult to understand that. See somebody 44 years old coming with endometriosis, and doctor advised her to remove the cyst, laparoscopic cystectomy, and do. She's only here very reserved, borderline, and removing the cyst or doing cystectomy will make it worse, and she'll never get pregnant. So basically, the right decision is important. That's what the factor affecting this kind of successful rate is important as well. Now, if you move to other factor, leiomyomas, it's very common. Is affecting about 30, and there's some publications say 50% of the population, mainly the Afro-Caribbean population. I mean, the ability how to affect infertility risk is still controversial. We don't know exactly, is it actually the implantation, is the miscarriage, but depends on the, where the fibroid and the size of it. Any fibroid over 7 centimeter is over 7 centimeter. And if the patient can get pregnant, especially if she have one IVF or attempt to at one IVF or one cycle attempt and she's not pregnant, please remove the fibroid, because it have impact on the contraction of the uterus, have impact on the endometrium, have an impact on the blood flow. I mean, you could give her one try. That's if the leiomyoma 7 centimeter and bigger and is not affecting the uterine cavity, still you have to remove it. Now, if it's less than that, you can't try. But again, depending on the age, you have to take many factors in consideration to know the right things. I mean, definitely has negative impact. There's many studies. I think Ramsey study is from America, published in 1998, and he has a chapter in Progress. So absolutely fantastic chapter to say the effect of the endometriosis. You can read it. So if you'd like to go for the classification, figure classification, you need to add number 8. There's a new thing. 8 means in cervical here in this area. So this affecting, of course, the implantation. This affecting implantation. This affecting implantation. But if this one over 7 centimeter, it does affect the implantation. You have to remove it. You don't have to remove some, like interstitial fibroid or intramural fibroid of 2 to 3 centimeters is not important. So basically, the patient age taken in consideration, and the size of the fibroid, and where is the fibroid. But if somebody 39 years old has 2 IVF and never pregnant, when going to wait? Because removing the fibroid, you're going to wait another 6 months before starting IVF, so you're going to be 39 in 6 months, or 40. So you have to take the right decision instead of wasting your time. Remove the fibroid if needed and do IVF. The duration is important. I mean, there's big publication from, I think, a big group in Nottingham. They say, if they actually, natural, even normal couple, unexperienced fertility, they spend together unprotected intercourse more than 2 years, the chance of pregnancy from control ovarian stimulation almost 0. So don't waste your time in the COS or control ovarian stimulation. Go to IUI and give it a chance, better chance. If not pregnant, IVF. Because unexplained, you don't know actually is a problem with the fertilization, is a problem with the endometrium. When you do IVF, retrospectively you can find the reason and you can treat the patient. So basically, somebody trying for a couple of years, no pregnancy, you have to be a bit aggressive in the treatment. 3 years, that means worse. After 3 years, according to even guideline in the college, after 3 years, no pregnancy from unprotected intercourse, IUI. Now, I'm sorry, this is because the slide getting bigger, so they moved. I was highlighting this. So this is Templeton. Templeton is a very wise man, used to be the Royal College president. Have that HIFA database, just actually ask him, give me the data, I'll analyze it, and analyze the duration of fertility. This is the first publication, 1996, for the database of the HFA, and found people trying more 1 to 3 years, live birth rate with IVF 15% at that time. But somebody trying more than 12 years, why need to increase the cost of the patient? Why need to do something unnecessarily, and it doesn't improve the chance of pregnancy? I'm going to conclude what has been said. The major fact affecting pregnancy and live birth rate are age and the rate decline after age of 38. Increasing duration of fertility is absolutely an important factor. I need to take that in consideration, please. Period of pregnancy is absolutely good factor, especially if ended in successful pregnancy. And ovarian reserve is a very successful predictor for the outcome, so you know how to choose the right dose, right patient, and right protocol. The hydrosalpinx negatively have a negative impact on the IVF treatment, so you have to treat hydrosalpinx before clipping or salpingectomy or respiration. Fibroid submucosal, you have to remove. Large fibroid over 7 centimeters, you have to remove. You have to advise the patient to lose weight, stop smoking before you start. And the most important thing, please tell the patient her chance of pregnancy and comparing that with the chance of pregnancy naturally. Thank you very much. Thank you. I think we'll leave the questions to the end to be easier. Thank you. Thank you. Should I sit here? Thank you. Salam ala Shano bas. Salam ala Shano is here. Thank you. We'll take a bit of time. Shano, how are you doing? Good to see you. You well? Good. How are you?
Very good, very good.
Take your time, really sorry.
Yeah, no problem.
Last time I saw you was in Kuwait as well. How are you?
كم بارك الله يعافيك رب الله يخليك كيف صحتك اخبارك يعطيك العافيه ويبارك فيك Nasser, how are you doing? Nice meeting. How are you? Nice meeting. Thank you. I'm fine, thank you. Did you have a nice journey?
Yeah, I arrived yesterday at 2 a.m. But anyway,
Oh, good. Thank you. Nice meeting.
I think it's working. It's still working.
Should I take this one?
Is that not working?
I think it's not working. No, this is better, I think.
Is it?
Yeah.
Okay.
No, this is better. It's absolutely
Okay.
fine. How's your journey?
Good. Just landed.
From UK in the morning. Amen.
What I do in my clinic and what I do with my colleagues is dividing them into negative and positive. So this is what happens to you and I every day in clinic. What are the negative factors? Female age, and we've heard that already. ovarian reserve, the reproductive history, the cause of subfertility, and the duration of subfertility. Okay? Without even knowing what NAHED was going to talk about, actually this sums up his presentation. What are the positive factors? Ovarian response, number of mature oocytes retrieved, number of fertilized oocytes, number of good quality embryos, and last but not least, number of available blastocysts. So, we know, and you don't need me standing here today, that ovarian function declines with age. And most patients coming to my clinic in the UK, they fall within the declining fertility age, where you can see there is also a lower chance of success. The data in the UK published by the Human Fertilization and Embryology Authority clearly show that age is an important determining factor, and as women get older, the chance of having a pregnancy declines. And we also know that as women get older, there is a higher risk, a chance of cycle cancellation, and a higher proportion of women have 4 eggs or less. We know that there are 2 phases. One is the initial recruitment, and the second one is the cyclic recruitment. What we can influence with the medications we give our patient is the cyclic recruitment and not the initial recruitment. And NAHED has already spoken to you about the relationship between AMH and antral follicle count. And what I'm going to do in the next probably 10-15 minutes is to talk to you about conventional ovarian stimulation. So the question we have to ask ourselves is what is the reproductive potential of antral follicles? What is the optimal response to controlled ovarian stimulation? What are the factors that affect ovarian response? What is the perfect number of eggs? And last but not least, is there a role of progesterone measurement? Now, in everyday practice, we believe that women having a large number of FSH responsive follicles should have a higher chance of pregnancy. I personally don't believe in mild IVF, natural cycles, IVF, and so on. I don't think there is point in putting a woman through an IVF cycle to collect 1 egg or 2 eggs. But we also have to be realistic, and we cannot assume that all the follicles at one point in time will respond to stimulation. And we also need to understand what's the difference between ovarian response and ovarian reserve. We know that there is a very close relationship between the number of follicles that are FSH sensitive and the number of follicles that will have mature eggs. And I don't want you to think today, or at least during my presentation, about ovarian response as the number of follicles that we get on day of trigger. Also, I don't want you to think about the number of eggs that we get on the day of a collection. But instead, I'd like you to think about something called FORT, which stands for Follicle Output Rate. If you and I are in the same clinic and we have a patient that's got 20 follicles on day 2, but on the day of trigger, she's only got 3 or 4 mature follicles, she's clearly not a good responder. You may have instead a lady's got 6 antral follicles, and on the day of trigger she's got 6 mature follicles. She's a good responder. So, although the second one may be found to be with low ovarian reserve, but she has responded well to treatment. So what I'm going to talk to you is about the relationship between the number of follicles at baseline and the number of follicles on the day of trigger. And that is what we use in our clinic as a prognostic indicator for subsequent cycles, but also to counsel patients if a cycle has not gone well. And you can see from this study that a low follicle output rate, where low stands for less than 30%, 32%, which means only 4 out of 10 of the original antral follicles have reached maturity, is associated with a poorer outcome as compared to cases when there is higher FORT, greater than 56%. And when you look at the IVF data, look at the implantation in the 3 groups, look at the clinical pregnancy rate in the 3 groups, actually that is reflected in the number of follicles that have reached maturity. So, if you sit in clinic and you do a baseline scan, and I absolutely agree with NAHED that all patients should be assessed at the beginning of each cycle and should not just put through an IVF cycle because they have had at some point in their life some investigations, and you do an antral follicle count and you see that there is a cohort of follicles, and you get to stimulation in trigger, and on the day of trigger the follicle output rate, so the ratio between the mature follicles and what you started with, is greater than 56%, 58%, 60%, then the patient will have a significantly higher chance of clinical pregnancy as compared to having a low follicle output rate. Okay? So after this, you can carry on thinking what you do in practice, but in my opinion, this is a more reliable measure to assess ovarian response. I will skip the slides for time, and I'll take you to what I believe to be also an important point to discuss with our patient, that the poor response to antral follicles, to FSH, is often associated with a degree of follicular and oocyte incompetence. And that's the reason why increasing the dose of medications is not always the solution. You know, when I started in 1999, 2000, I remember I was working at Hammersmith Hospital, and at the time patients were taking 600, 900 international units of gonadotropins daily. Now, in my opinion, there is no benefit in increasing the dose of stimulation if the oocyte, the follicles, are incompetent. And again, we are about to complete a study in my clinic looking at the relationship between the dose of medications in subsequent cycles and the follicle output rate. Okay? 83% of a patient population will have exactly the same follicle output rate irrespective of dose of stimulation. We have 3 groups, 150, 225, and 300. So, there is a reduced ovarian response to controlled ovarian stimulation in older women, and that is probably associated with the depletion of the primordial follicle pool. And we need to reconsider the cancellation. I wouldn't cancel a patient that starts with 2 antral follicles and she's got 2 follicles on the day of trigger. But probably I would consider canceling but she's got 2 mature follicles and start with 20. Because the chances of that patient having a competent egg is very poor. And what we know, and this is another interesting study, is that there is a relationship between AMH levels, which you've heard from NAHED already, and the follicle output rate. Higher is the AMH level, lower will be the follicle output rate. And this is what happens in some of your patients, in my patients, especially in your patients with polycystic ovaries. You simulate, they have 30 follicles, then you get to 4, 5, 6, 7 mature eggs. And this is important. It's important because perhaps we need to reconsider not just the dose of stimulation for this patient, but also the length of stimulation.